Good afternoon. My name is Ninez Ponce, and I'm the director of the UCLA Center for Health Policy Research, professor and Fred W. and Pamela K. Wasserman Endowed Chair in the Department of Health Policy and Management at the Fielding School of Public Health. And today, my proudest role is to be the principal investigator of the California Health Interview Survey. As a land-grant institution, we would like to begin by acknowledging the Gabrielino Tongva peoples as the traditional land caretakers of Tovangar, that is the Los Angeles Basin and South Channel Islands, and this is where UCLA currently sits. Thank you for being here today. I know some of you have joined us in previous years, some of you are new, but thank you for being here. This is always one of our most exciting days each year. A lot of anticipation, definitely a lot of sleepless nights for some of us here, but very exciting. This is the release of the newest California Health Interview Survey data, the CHIS. If this is your first time, again, a warm welcome to you. And just super thanks for those who have been with us in our journey for many years, have joined us. Thank you for your continued support. So the California Health Interview Survey, which you will hear us refer to as CHIS, is the nation's largest population-based state health survey. It's used by policymakers, by local health departments, by state agencies, community organizations, foundations, researchers, but also advocates, journalists, and many more. The CHIS provides reliable, actionable data on the health and healthcare needs of California's diverse population. The CHIS serves as an exemplar of how we ensure that our research gets into the hands of the people who can use it. And over the last 23 years, the California Health Interview Survey has played a critical role in identifying health issues, health inequities, shaping health policies, interventions, and programs that improve the lives of Californians and people across the nation. So during the next hour, my colleague, the CHIS Director Todd Hughes, and I will be discussing some of the key findings of the 2023 survey, ranging from experiences with housing discrimination to gambling to voter engagement to medical debt to mental health and more. As usual, there's a lot to cover, and we're not going to cover everything that's in CHIS, but we'll try to do as much as we can to feature some new content. Slide 2, please. Please stay informed, and as always, the webinar is being recorded and will be posted to our YouTube channel in the coming weeks. If you would like a copy of today's slides, please email our communications department at healthpolicy@ucla.edu. Slide. I'd also like to share information about some upcoming events. While today is about us sharing highlights from the CHIS 2023, on Thursday, October 17th, it's a week from today. Oh no, 2 weeks from today. We will show you how to access and use CHIS data. So join us for a special data user training where you will learn how to use CHIS's free online data tools, AskCHIS, and its younger but more granular sister, AskCHIS Neighborhood Edition, which features estimates at the local level to as granular as the census tract level. 2024 is a remarkable year. It marks the 30th anniversary of the UCLA Center for Health Policy Research. And we've got some exciting events planned over the next 6 weeks. First, on Thursday, October 24th, please mark your calendars, we will host the 2024 E.R. Brown Symposium, which is being held in person at the Hammer Museum. This year's symposium will showcase the innovations and impact that have made CHPR one of the nation's leading health policy research centers and envision the future of health policy through new advances in research, evaluation, and community engagement. And when Todd is on, I'll put into chat a little bit about our founding director, Richard Brown, we only know as Rick. And we are honoring Rick. He was also the first CHIS PI. We're also delighted to share that Dr. Aaron Carroll, President and CEO of Academy Health, and a nationally recognized thought leader, pediatrician, health services research, and New York Times contributor, will provide the keynote address, and this is on October 24th. The event is free, open to the public. There will be lunch, but registration is required. And slide 5, please. So, and finally, on Wednesday, November 13th, we will host the UCLA Center for Health Policy Research 30th Anniversary Gala and Awards Dinner to celebrate the achievements that have been realized over the past 3 decades and honor the people who have been instrumental in making this work possible. Enjoy dinner, drinks, live entertainment, bid on exclusive silent auction items, celebrate the strides we've made together. It's going to be a grand party. Our communications director will be putting those links in the chat. I think this is happening right now. And we have several CHIS staff here today monitoring and responding to some audience questions in the chat. We will reserve the last 15 minutes of the webinar for the Q&A, and we encourage you to ask questions throughout the presentation using the Q&A function in Zoom. Again, thank you for joining us today, and now let's get started. So what is the California Health Interview Survey? It is the nation's largest state health survey. It's population representative. It's a comprehensive source of health information on Californians. The topics are cover a vast, vast dimensions of not just health and health care, health insurance, but a lot on respondent characteristics. So CHIS is a collaborative project funded by federal and state health agencies, California and national foundations, and many others. So lots of supporters of CHIS. And if you're out there joining us today, thank you. This is a picture of our making the numbers, like our numbers in making an impact. And we see that we report on access to data tools, legislation advocacy, seminars and events and presentations, journal articles, publications, and media coverage. So there have been close to 2 million, so 1.8 million queries on AskCHIS. This is one of our free online query tools, as well as with AskCHIS Neighborhood Edition. So combined, we have 1.8 million queries. But because, particularly for AskCHIS, when you think about just in 2023, there's over 100,000, so 107,000 plus queries using AskCHIS and AskCHIS Neighborhood Edition. And if one of our team members could just put the link to AskCHIS and AskCHIS Neighborhood Edition, I'll talk about it more. I think Todd will talk about it more towards the end of the presentation, but in case you're curious right now, so you can see what the link is. And we interview, we have information on over 20,000 households. In 2023, it was we exceeded the 20,000 household mark and collected information on 22,423 households. And the questions we ask are absolutely salient to California's population, which is why the media is very interested in our insights. There have been over 435 media hits, featuring CHIS, our researchers here at the center, also researchers, far and wide, even globally, that have used CHIS to help them understand issues on population health, issues on immigrant health, issues on LGBTQIA+ health. So it's we've been featured in Los Angeles Times, ABC, and many more. CHIS has public use files and also a data access center where you can do queries and use statistical programs, test your hypothesis, see how it works out in a population representative survey such as CHIS, which has a lot of variables on health and health access and many variables on demographic characteristics. So nearly 100 publications in 2023 that we found in our search. There could be more, particularly in venues that aren't necessarily in PubMed or in other health-related publication search schemes. So there's currently 391 total variables and topics. So if you use AskCHIS, it keeps, if you've been with us every year, this number is growing exponentially because even though you may just have an addition of, say, 50 more variables, but the combination, the arrays of the crosstabs and limiting the population using AskCHIS then generate more than the additional variables, but insights that are then exponentially more. So we now are posting about 10 million, 10 million estimates you could possibly do on AskCHIS. Next slide. How is CHIS conducted? And for those of you who were contacted by UCLA and have graciously accepted to be a participant in our survey, you'll know that we do interview adults 18 and older, and in the household, adolescents 12 to 17, and that's with parental permission, and adolescents respond for themselves. And then if present, and child ages 0 to 11, which the most knowledgeable adult will respond about questions on the child, again, if present in the household. CHIS is the randomly selected, it's not everybody in the household, it's random selection of an adult, and if present, an adolescent and a child in a household. To ensure that we reduce coverage bias, that means so that we can make sure that we hear from Californians, and we try to break down any barriers of participating in the survey, language being one of them. That CHIS is conducted in multiple languages, English, Spanish, Chinese, both Cantonese and Mandarin dialects, Korean, Vietnamese, and Tagalog. Next slide, please. So again, how is this done? It's called address-based sample, push to web, and also telephone response follow-up. So we send a letter out with $2 as an incentive. It's kind of it's not coercive, but it's notable, and and it's unique. So not many people have seen $2 bill, nice, crisp. And then we asked the sampled adult in the household to respond, to go online, to do the web survey. And if they want, they can call in. If they don't want to do the survey on the web, or they don't have a computer, they have poor bandwidth, they can't negotiate the computer, as sometimes I have that problem at times, then you can call by phone. If we don't hear from you, then we start calling you by the telephone. So there's a follow-up, but we don't bug you in eternity. We bug you about 6 times. Next slide. We do our methods. We design our methods to make sure we reflect California's diversity. So we do this by targeting sampling methods. So we target areas, for example, that have high concentration of Spanish speakers or Cantonese Mandarin speakers. There's multi-mode data collection, and there's language support that we have if the survey has to be done in another language, I said, then we have language support for that respondent. We have custom oversamples. Some groups, particularly local health departments, have approached us and say, I want to oversample in my county, and I want to focus on, for example, low-income individuals, or working adults who may have been essential workers, to specific racialized and ethnic groups as well. So, and then the other part we do is, it's not done, it's done with a lot of vetting and making also sure that we don't overburden our respondents, is that researchers may have a hypothesis and they submit to NIH, or it could be a government agency that wants to go to get more information on a specific group, like caregivers for long-term services and supports, looking at how, for example, how information is trusted or used by the Latino population. So these are what's called follow-on surveys, where researchers use the population-based sampling recruitment of CHIS. So there's a population-based sample, and then we recontact these individuals to participate in a specific survey. As one of the examples, as I had already mentioned, is a follow-on study on long-term services and support. Because of our quest and make it happen to make sure that our methods reflect California's diversity, we did receive the American Association for Public Opinion Research's 2024 Inclusive Voices Award. This award recognizes important data sets, research, survey methods that have improved the ability to study complex social phenomena related to understudied populations. So we're very happy to accept that from APOR. The results by race and ethnicity, by racialized and ethnic groups, are displayed here and displayed by the current, by the OMB, not the current, because the Office of Management and Budget actually deployed new standards on March 28, 2024. But this is based on the old standard where we have 5 major racialized groups, including tabulating for more than one race and also for other single race. And so we present our sample sizes here for the adult survey, for the adolescent survey, and for the child survey. And then we have the Latino ethnicity question overlay. Again, this is per the 1997 Office of Management and Budget Statistical Policy Directive 15 standards, but they have changed and we will change just accordingly for 2024. Next slide. So the supplemental sampling methods for 2023 CHIS is that another way of getting at populations that we don't ordinarily get in kind of same old way of sampling, that we have to try harder for populations that are harder to reach. So we have to try harder to reach these populations. So one strategy we've been employing is the use of prepaid cell phone samples. Prepaid cell phone samplers could be used by folks who are unhoused, by seasonal workers, for example. And so we target 450 completes, an objective to increase representation for respondents who are younger, 18 to 24, Hispanic or Latinx, Black or African American, and who also prefer to take the survey in one of the non-English languages that we had offered, Spanish, Cantonese, Mandarin, Korean, Tagalog, and Vietnamese. Next slide. Next slide, please.
One quick second. We're having a little bit of a technical difficulty.
Is it a delay? Was it a delay?
We're back.
Okay, we're back. We can proceed to the next slide. We also have other targeted oversamples. I had mentioned that one of our set of partners and users are local health departments, and San Diego County Health and Human Services has, I think since the inception of CHIS, so since just 2021, we've done targeted oversamples of San Diego County with their health districts. The City of Long Beach Health and Human Services, we added additional 500 adults. And Santa Clara County Public Health Department, an additional 1925 adults. Next slide. This is the, how much is the data now available? And I think I had said 100 million. I probably overstated it. It's actually 19 million different CHIS estimates can be explored in AskCHIS now, because we have 536 total variables in 2023, and then you can use this for two-way crosstabs, as I had said, and you can look at 66 different geographic areas. So it's another overlay leading to potentially 19 million estimates. So the 2023 public use files, again, for you researchers out there that want to download, use R's data and SAS to conduct your empirical analysis, that there's now 1493 detailed variables for research. Next slide. Some noteworthy additions to CHIS 2023. We now have a module on housing discrimination, on unintended pregnancy, adolescents' college plans, adolescent sexual orientation, many other topics. And also I will specifically talk about a fact sheet that we also released today on gambling. So the QR code is here for you to take a picture. And so you can then get the What's New document to our CHIS methodology reports. So I now turn it over to my colleague, Todd Hughes, who is the director of the California Health Interview Survey. Todd?
Great, thank you so much, Ninez. So it's my pleasure now to share with you some of the findings from the 2023 CHIS. And as Ninez mentioned, with over 536 topics or indicators and over 19 million different CHIS estimates for 2023, I can only give you a very small glimpse here of what we can learn from today's data release. And first, I'd like to revisit the issue of food security, which we also highlighted last year. So the CHIS asks adults earning less than 2 times the federal poverty level, which is $60,000 for a family of 4 in 2023, about this topic, and continues to measure a rising trend from 2020 through 2023 that more adults are not able to afford enough food or are currently receiving food stamps. The 2022 and 2023 rates are comparable to each other, and both years are higher than 2020 and 2021. In 2023, 44.5% of adults under 200% of the federal poverty level reported being food insecure or not being able to afford enough food, a statistically significant increase from the 2020 and 2021 rates of 35.8% and 39% respectively. Similarly, increasing numbers of adults in this income range are currently receiving food stamps, 34.9% in 2023, which is significantly higher than the rate of 28.5% in 2020. Next, let's examine the issue of medical debt. 1 in 10 California adults report having problems paying for their own or a household or family member's medical or dental bills in the past 12 months. And we asked adults who had problems paying for their medical bills about the financial impact of these medical debts. More than 1 in 3, or 36.4% of them, reported that they were unable to pay for basic necessities like food, heat, or rent because of their medical bills. More than half of adults who had problems paying their medical bills in the past year reported incurring credit card debt to pay for those medical expenses. And this percentage has been steadily rising from 45.2% in 2020 up to 56.3% in 2023. In May 2022, the state expanded Medi-Cal, the program that provides health insurance to low-income Californians, to offer full benefits to qualifying adults 50 or older without regard to immigration status. CHIS showed that in 2023, that 51.8% of non-citizen adults, including those with green cards, were covered by Medi-Cal, an increase from 41.1% the previous year and 39.2% in 2021. Questions about unintended pregnancy were a new addition to the 2023 CHIS, and we found that 4.4% of sexually active women aged 18 to 44 reported an unintended pregnancy in the past year. And we identified significant differences in the rate depending on income. Women earning less than 200% of the federal poverty level were more than twice as likely to have an unexpected pregnancy compared to women earning more than that, 7.5% versus 3%. Similar differences in rates for unintended pregnancy were observed when examining birth control use to prevent pregnancy. 7% of sexually active adult women that do not use birth control to prevent pregnancy experienced an unintended pregnancy in the past 12 months, versus 2.7% of those that do use birth control to prevent pregnancy. We've been reporting for a few years on some troubling trends since the pandemic in regards to adult mental health needs and access to mental health care in California. 2023 rates remain higher than 2019 and 2020 for several mental health measures, including needing help for emotional or mental health or alcohol or drug problems in the past year, seeing a counselor, psychiatrist, or social worker in the past year for emotional, mental health, or alcohol or drug problems, and difficulty in getting an appointment as the reason why people didn't get the emotional help they needed. So we saw these peak in 2021 or 2022, and the 2023 rates for these measures are still comparable to those highs. However, this year, we do start to see some changes in the trends for a few adult mental health indicators that are actually coming down in 2023 from post-pandemic highs in 2021 and 2022. Specifically, rates in 2023 returned to 2019 and 2020 levels for three key indicators: likely having serious psychological distress in the past year, severe social life impairment due to emotions in the past 12 months, and severe family life impairment due to emotions in the past 12 months. So each of these, we are starting to see some improvements, which is encouraging. Although there are some signs of improvement for mental health, we do see some inequities of concern, including a correlation between economic instability and poor mental health. Specifically, adults with unstable housing were more than twice as likely to say they had serious psychological distress in the past year compared with adults in stable housing. So 30% versus 13.1%. And those with unstable housing also had higher rates of reporting that they had ever seriously thought about suicide, 28.2% versus 19.2%. Additionally, those with income levels below 200% of the federal poverty level had statistically significantly higher rates of serious psychological distress in the past year, 17.5% compared to 14.4% for those with higher incomes, and higher rates of ever seriously thinking about committing suicide, 21% versus 19.1%. Although the CHIS has asked adults about their sexual orientation since the inception of the survey in 2001, the 2023 questionnaire included modified response categories and also began asking about sexual orientation for adolescents aged 12 to 17. Adults reported being straight at a higher rate than adolescents, 84.4% versus 76.8%, and also reported that they preferred not to answer the question at a higher rate than adolescents, 4.5% versus 3.2%. Adolescents reported higher rates of being bisexual or pansexual, 9.8% for teens compared to 5.1% for adults, and also reported that they didn't know their sexual orientation at higher rates than adults, 6.7% versus 1.8%. Overall, 1 in 8 adolescents, or 13.3%, report that they are gay, lesbian, bisexual, pansexual, or use a different term, compared to 9.3% of adults. And looking now at the mental health needs of adolescents, we do see disparities by sexual orientation. Adolescents that identify as straight have statistically significantly lower rates than the rates for all adolescents for experiencing serious psychological distress during the past year, needing help for emotional or mental health problems, or receiving psychological or emotional counseling in the past year. Rates of serious psychological distress during the past year were almost 3 times higher for gay or lesbian adolescents at 67.8%, and more than 2 times higher for bisexual or pansexual teens at 57.6% than their straight peers at 23.3%. Wide differences were also observed for needing help for emotional and mental health problems among gay, lesbian, bisexual, or pansexual adolescents compared to straight teens. The rate for gay and lesbian adolescents was so close to 100% that it's considered statistically unstable, an artifact of having so many in this group of our survey respondents reporting this need. Continuing to examine these rates with additional years of data will help us address the statistical instability, but the data clearly show that the mental health needs of sexual minority adolescents do have disparities compared to the general population. Next, let's look at the topic of college plans for adolescents aged 12 to 17. 2/3, or 67.8% of adolescents think they are very likely to attend college, with 1/4, or 25.4%, thinking they are somewhat likely to attend. 6.8% of adolescents think they are not very likely or not at all likely to attend college. The rates of those being somewhat likely to attend college differed significantly by sex and by family type. 96.8% of female teens were somewhat likely or very likely to attend, compared to 89.8% of male teens, and 96.2% of adolescents with married parents versus 86.8% of teens with single parents. It's also interesting to examine college plans for adolescents in the context of adverse childhood experiences and positive childhood experiences. Adolescents that report having even one adverse childhood experience, such as abuse, neglect, or household challenges like poverty, divorce, or death of a family member, were less likely to be very or somewhat likely to attend college, 90.5% versus 95.2% for those who reported experiencing no adverse childhood experiences. Conversely, the presence of positive childhood experiences, such as having supportive family and friends, feeling safe and protected, or having a sense of belonging at school and in their community, had a positive correlation with adolescent college plans. 94.5% of those who experienced 3 or more positive childhood experiences were very or somewhat likely to plan to attend college, compared to 88% of those with less than 3 positive childhood experiences. Higher rates of adolescents being very or somewhat likely to attend college were also found among teens with higher levels of community engagement. 98.8% of those that have ever volunteered to solve a problem in their community reported being very or somewhat likely to attend college, compared to 91.5% of those who don't volunteer. Rates were also higher among those that believe they can make a difference in their community, 94.8% versus 89.3%, and among those that believe that people in their neighborhood can be trusted, 94.7% versus 87.5%. Housing discrimination was another new topic added in 2023 to the CHIS. Collecting data about topics like discrimination and housing insecurity further our understanding of how people's day-to-day experiences are also associated with health outcomes. Among California adults, 4.6% said that they experienced housing discrimination in the last 2 years. The data showed that 9.4% of Black or African American adults experienced housing discrimination, which was more than 4 times higher than the rate for white adults at 2.3%. CHIS also showed that 7.6% of multiracial adults and 6.9% of Latinx adults experienced housing discrimination, which are also statistically significantly higher than the rates for white or Asian adults. The next slide examines relationships between housing discrimination and citizenship status, income, language spoken at home, and type of residence. We identified statistically significant differences in each of these areas. Non-citizens were more likely than U.S.-born or naturalized citizens to experience housing discrimination at 6.6% versus 4.3%. People whose income was less than 200% of the federal poverty level, again, $60,000 per year for a family of 4 in 2023, experienced housing discrimination at more than twice the rate of people earning more than that, so 8.8% versus 3.1%. Adults who speak 1 or more languages other than English at home said they experienced housing discrimination at almost twice the proportion of adults who speak English only at home, 6% versus 3.5%. And finally, renters were 2 to 3 times more likely than homeowners to experience housing discrimination, whether that be in a single unit dwelling or in a multi-unit building. When we asked for the reason why the victims of housing discrimination believed they received or experienced discrimination or harassment, the most common response was race or skin color at 45.2%, followed by ancestry, origin, or language at 30.6%. Gender, sex, or gender identity, disability, or immigration status, each were also reported as the reason by more than 10% of our respondents who experienced housing discrimination. Note that more than one reason may apply for each person on this list. CHIS also showed a disturbing pattern of how race and ethnicity continue to correlate to being stopped by police. While the numbers for all California adults who were stopped by police in the last year decreased from 21.5% in 2021 and 20% in 2022, down to 16.8% in 2023. However, the numbers for Black or African American adults actually increased from 26.7% to 30.2% in 2023. There was a statistically significant increase in police stops from 22 to 23 for Latinx, white, non-Latinx, and Asian non-Latinx adults. Next, given that it's election season, we'd like to share the latest CHIS data on voter engagement and then examine how it corresponds to some issues impacting health. Nearly 2 in 3, or 65% of U.S. citizen adults, report being either always or frequently engaged in national, state, and local elections, but the rates do vary significantly by age group. Voter engagement increases with age, with the lowest rate of 38% among young adults age 18 to 24, and the highest rate of 83.1% among those age 65 and older. The highest rates of voter engagement by race and ethnicity were found among white, non-Latinx adults at 78.2%. Additionally, voter engagement was also higher for gay, lesbian, and homosexual adults than for straight adults, 77% versus 65.2%, respectively. But unfortunately, we do find in the 2023 CHIS data that some characteristics connected to poorer health outcomes or characteristics adversely impacted by some election issues are also associated with lower levels of engagement in national, state, and local elections. This slide compares voter engagement to birth control use, needing help for emotional or mental health problems or use of alcohol or drugs, serious psychological distress, and access to care. Significantly lower rates of voter engagement were reported among sexually active females that do not use birth control at 38.8%. Among those that report needing help for emotional or mental health problems or use of alcohol or drugs at 62%. And among those that are likely to have experienced serious psychological distress in the past year at 53.6%. And also among those that do not have a usual place to go when they're sick or need health advice, 45.7%, versus each of their associated comparison groups. Similarly, this slide examines voter engagement compared to housing stability, income, and food security. And we observed lower voter engagement among those with unstable housing, 48.8%, versus those with stable housing, income less than 200% of the federal poverty level at 47.1%, and those not able to afford enough food at 42.3% compared to their associated groups. At this point, I'm very happy to turn it back to Dr. Ponce for some discussion about a recent fact sheet on gambling and associated health risks in California.
Thanks so much, Todd. I was looking at the hellos in chat and I counted 16 counties in California represented. We have 58 counties in California and 5 states, Arizona, Pennsylvania, Washington, New Jersey, Massachusetts, and someone, Melissa from Mexico City, which is like, I did a specialist shout out to Melissa. Gambling, sorry, still in like voters, but gambling. Let's talk about gambling. Gambling becomes more commonplace And so data from the newest California Health Interview Survey show associations between gambling and a risk of poor health outcomes, as well as mental health problems, mental health challenges. We added questions in 2023 to gain insights on how gambling affects Californians and associations with some key indicators of health and health-seeking behavior. So we found that over 7 million, so about 7 million Californians, or 1 in 4, gambled in the past year. And our fact sheet, which I think we will have a QR code, or maybe that was in the previous slide, but Tiffany will put what the fact sheet is, can show you how we constructed our measures of what gambling, what constitutes gambling in California. And then of those who reported that they gambled in the past year, that there were symptoms of problem gambling that we worked with our technical advisory group and with California Department of Public Health on these symptoms. I'll talk about these in subsequent slides, but about 6.7%, or close to 500,000 Californians that report they had symptoms of problem gambling. And then of those who reported, so back to those who reported gambling in the past year, of 7 million, 7.2 million adults, we look at the gender distribution, the binary gender distribution. I know there's a question in Q&A about gender. So it's 28.1% for men, which is significantly higher than women, 21.7%. By age, actually older adults, 50 to 64 adults, reported gambling in the past year, 29.1%, which is statistically higher than young adults, 18 to 24, 17.6%. We also have veteran status in CHIS, and by veteran status, we have 32% of veterans reported gambling in the past year, statistically higher than non-veterans at 24.4%. By race or ethnicity, compared to the overall rates of Californians who gamble, we did find significantly higher rates among American Indians and Alaska Native adults and Black African American adults, so 40.4% and 34.0% respectively. The percentage is like 20, it's 24.8, that's the 1 in 4, so much higher. White adults, it's about the same as the population average, and actually Asian adults was lower, and it is actually statistically lower. You'll also notice that we haven't been presenting race or ethnicity statistics for the Native Hawaiian or Pacific Islander population. In one of my earlier slides, we showed that there were 77 respondents completed information on Native Hawaiians and Pacific Islanders. So some of the estimates, or a lot of estimates, are statistically unstable, unreliable. But as Todd had said, we can pool more years of data to increase the sample and have statistically significant results. But you can't do this for gambling because it's the first year that we've asked. But as we continue, if you continue with a set of this module on gambling, then we can start pooling, particularly to get insights on populations that are lower in number. By employment status, compared to adults, so adults who work full-time are actually significantly high, reported significantly higher rates of gambling compared to adults who work part-time and adults who are unemployed but looking for work. Next slide. And then adults who reported any gambling in the past year then also reported other types of behaviors that were associated with increased risk of poor health outcomes. These are associations, these are not causal, but they are associations that could be concerning, that among adults who reported gambling, 24.4%, also reported binge drinking, 6.4%, also reported e-cigarette or vape use, 2.4% reported substance use, and 7.2% reported being current smokers. Next slide. So this kind of gets at what problem gambling is. So among Californians who gambled in the past 12 months, this is not a non-exhaustive list, but this is domains that we work with our technical advisory committee. 1.6% of adults reported they needed help with living expenses from friends, family members, or public assistance programs because of gambling, kind of a symptom of problem gambling. For adults that report that who gambled, they reported they had kept their friends or family from knowing how much they gambled, so they kept it secret or hidden. Another symptom of problem, that's another symptom of problem gambling. And then 4.7% reported feeling of those who gambled. Again, the denominator here is adults who reported gambling in the past 12 months, reported feeling restless, irritable, or anxious when trying to quit or cut down on gambling. Next slide. So what does this tell us if an adult has symptoms of problem gambling that I just described? Well, there's also associations of problem gambling with serious psychological distress in the past year. So among those where we detected symptoms of problem gambling, 1 in 4 of those adults who had symptoms of problem gambling experienced serious psychological distress in the past year. And nearly 1 in 7 of adults without symptoms of gambling problems, so a much lower proportion, did report symptoms of serious psychological distress. So again, just an association, but showing some patterns in the data on much higher propensity of having symptoms of problem gambling among gambling adults who had symptoms of problem gambling. Next slide. And, will adults then get help for mental health, alcohol, or drug use in the past year? We found that almost 33% of adults who had, kept their family or friends from knowing that on how much that they gamble. So a high proportion, 33%, who saw any healthcare provider discuss their mental health or drug use in the past year. So it's 33%, but then you have, the other, 76%, 67%, close to 70% who are not seeking treatment. 27.6% who became restless, irritable, or anxious when trying to quit or cut down on gambling actually saw a healthcare provider. Again, the flip side of that, then you've got close to 70% not seeing a healthcare provider. 18.4% of adults who sought financial help from family or friends because of their gambling, and 28.2% of gambling adults with any symptoms of problem gambling, altogether. So I think what the data is showing that there are segments of the California population who have symptoms of problem gambling that are seeking help, seeking treatment, but there's also a high proportion, and we can explore that, or I invite you to explore the demographic associations to craft policies and programs to ensure that there's help. Next slide. I turn it now to Todd on how to access CHIS data.
Great. I know we're running out of time a little bit, so let me try to move quickly through some of these slides, but I just want to share with you, number one, how important it is for us here at CHIS to ensure that all of these rich data that we have collected can be accessible to users at all level of skill sets, at all different kinds of organizations, to really democratize access to the data and reach a diverse audience. And so we have a number of different tools that we use in order to enable that. For our most statistically savvy power users of the data, we do have the ability through our Data Access Center for us to collaborate with external researchers, and using our internal statisticians, program analyses on the confidential data sets here that we would then release the outputs after they've been reviewed for protections of responding confidentiality. If you have those ability to do the programming yourself, and you want to use a slightly less restricted data set, the public use file has been screened and formatted to be able to reduce the risk of any violations of respondent privacy or confidentiality, and can be downloaded in SASSENS data for independent analysis. And then we have multiple tools that are available online in a free manner. Our AskCHIS platform is the most powerful tool that we have for you to run cross-tabulations of any of these topics on the survey by various demographic characteristics or other indicators on the survey, as well as the Neighborhood Edition platform, which is focused more at low levels of geography all the way down to the census tract, and health profiles, which are basic dashboards of some key indicators for perhaps some of our least statistically savvy data users. I also want to say that each year our sample design supports producing direct estimates for each of our 56 geographically defined strata. Unfortunately, in some of the smallest population counties, there's just not sufficient size for us to, with our total statewide sample, which should ideally be proportionally based on population, for us to produce independent estimates for those counties each year. And so we do group 3 of these groups of the 17 smallest counties into 3 multi-county strata. 2 of the largest population counties, Los Angeles and San Diego, do include sub-county estimates each year for the 8 service planning areas in Los Angeles and the 6 health regions in San Diego County. And then the remaining 39 counties each form their own individual sampling strata. And then to produce low estimates for lower levels of geography in some of our modeled estimates, it requires 2 years of data to produce those modeled estimates. So again, the direct estimates for those 56 sample strata that I referred to before, those are available in the AskCHIS platform. So we have state level estimates as well as those county level approximately, or sampling strata level more specifically, level estimates with the 2023 data now available in AskCHIS. And then to get lower than that, down to assembly, senate, and congressional districts, cities and zip codes, and census tracts, we produce modeled estimates once every 2 years. And the latest data that we have available now is with the 2021-2022 CHIS data in a newly redesigned platform for AskCHIS Neighborhood Edition. And I know that Tiffany has already put the links to that in the chat earlier. But the AskCHIS Neighborhood Edition platform allows you to be able to really dig down. You can type in a street address and query and find out what census tract that's in, what congressional district, state assembly, or state senate district. And then you can also create combined geographic areas, so a custom user-defined geographic group where you link multiple tracts or multiple districts together, and then look at the health indicators of choice for that geographic area. You can also use this platform then to produce those small level estimates for census tracts or cities, and produce an output in tabular format where up to 5 different geographic areas can be defined, and you can select multiple different health indicators and compare across those geographic areas. So really encourage you to check out AskCHIS Neighborhood Edition if you'd like a little training on how to use those platforms. So within AskCHIS Neighborhood Edition, there's a tutorials tab right at the start of the landing, and you can watch brief videos on how to create maps and create tables. If you'd like more in-depth training, we have a training library available at this link where a full previously recorded data user webinars are available for you to get an in-depth training on how to use our various data tools. And then lastly, for our online health profiles, I mentioned these are brief dashboards where we generally combine 2 years of data, and the latest data available for these dashboards combine 2021 and 2022 CHIS at this point. And it shows breakdowns by county, region, LA service planning area, and San Diego health regions, and also breakdowns by racial and ethnic group, and many Latino and Asian subgroups as well. So at this point, I just want to express some thanks to our data collection partner, SSRS, our content partner, the Public Health Institute, PHI, the members of our advisory boards and committees, and the rest of the UCLA CHPR team listed here on the slide, who are all seated just a few feet away from me in our conference room watching today's webinar. And also special thanks to our communications team, Tiffany and others, as well as our IT staff for their support of this release. And I encourage you to find us at chis.ucla.edu. And at this point, I'll turn it back to Tiffany for Q&A.
Hello, everyone. Thank you for joining us again. We have limited time, so I'm just going to jump right into the questions. Maybe this was already addressed. Were you able to reach hard to reach populations and meet your goals for representation?
So I'm so proud of the work that we do at CHIS, using all of these different strategies that Ninez covered, really targeted sampling methods that are very powerful to find underrepresented groups across the state, the use of our multiple modes and language support, the use of the prepaid cell phone sample as a supplemental source. I think the CHIS does an outstanding job of representing the various racial and ethnic group, language groups across the state of California. These data, demonstrate where that, what the results for that look like. Is there room for improvement? There's always room for improvement. Are we looking for ways to improve? We're always looking for ways to improve.
Thanks, Todd. Have you studied reliability of self-reported information for all subjects in the survey? Are samples considered big enough that this is not an issue?
Well, that is certainly sorry, Ninez, do you want to?
No, I think that's a general critique of any surveys because it's self-reported. It's subjective assessment of their situation, but you can also argue a person's subjective assessment of their situation may be better than an external person, filling out the form for you or making that assessment. So there's definitely a host of studies and literature on the, on subjective and objective, and sure, there's going to be perhaps differential validity of subjective if you anchor it to objective measures like claims data, clinical data. But I think in the past we've just always seen that this is a population-based survey, and we want to hear from the people of California and what their experiences are.
Definitely. Does CHIS or the center have plans to explore any of these issues in more depth?
Yeah, so let me say specifically, we are working with the California Civil Rights Department in a deeper dive into the topic of housing discrimination, as well as additional questions that we didn't go into detail today about hate incidents. So those two topics are scheduled to have some reports developed by our Center for Health Policy Research towards the end of next year after we have compiled the 2024 CHIS data as well. And then we continue to have ongoing partnerships with the Department of Healthcare Services Community Service Division to look at various reports connected to the mental health data that we collect in CHIS. So those are some of the currently committed reports that we do have plans to produce additional analyses for.
Thank you, Todd. There are about 27,000 people in Del Norte County. You aggregate with like 6 other counties. You have a sample of 209 households for all of these counties. Why so low? If there are still 27,000 in Del Norte, how come the sample size is this small? I only ask because my work includes evaluation for Del Norte all the time, and data problems like this are constant.
We can certainly, we have empathy for what you're trying to accomplish and understand the sample limitations that we're working with. So the population, the sample selection across the state of California to be the most statistically reliable as possible would ideally be proportionally allocated according to population. So for, the counties that have the lowest population, proportionally allocating the sample to those counties, doesn't give us enough sample for statistical reliability. And so we've established a floor of a minimum sample target in some of the medium-sized counties, but for these 17 smallest counties, the only solution we have currently is to group them into multiple counties. Now, that said, the AskCHIS Neighborhood Edition platform does allow you to have modeled estimates for those county level data, even at these, small population counties, and census tracts within those counties every 2 years, when we can aggregate enough sample to produce those modeled estimates. So we have done that as an approach to try to provide small area data across the whole state. And we're continuing to explore other modeled estimate approaches to be able to produce county level estimates for other indicators.
Thank you.
We can also work with you, Del Norte, with our data access center. And if, we can pull several years of the aggregated counties, but then pull out the Del Norte, So do keep in touch with us, and we certainly work with you.
Thank you. We are out of time, but let me ask one more question. Is there a state plan to use the data to inform upstream policy to mitigate the adverse high prevalence of information identified? If so, what are the current policy work on these issues you described?
It seems like a larger question to the state under Chief Data Information folks, but I can attest that we take the utmost precautions on ensuring we're mitigating disclosure risk, having our data be housed here where only like those folks who go through a vetting, including FBI, clearance, and that only our statisticians in that room. I am in the center, but I am not in the room where Todd and the other folks are, have access to the data, which is actually de-identified. So I think we do try our best to make sure in terms of the confidentiality is upheld.
Thank you. So that is all the time that we have. I just dropped the links for the CHIS data user training that's happening on Thursday, October 17th, the 2024 E.R. Brown Symposium that's on Thursday, October 24th at the Hammer Museum, and our 30th anniversary gala and awards dinner on Wednesday, November 13th. If you have any questions about any of the events, you can email us at healthpolicy@ucla.edu. If you would like a copy of the presentation, definitely email us there as well. Thank you to everyone for attending today. This is always one of our favorite days of the year, so we really appreciate you being here with us. Have a good day.
Thank you. Thank you. Thank you. Bye.